Hello.
Yes, sir. Please, sir.
Okay. Good afternoon. Good afternoon. Welcome to all to our webinar 2103. I'm happy to announce today's webinar on diagnosis and management of ITP and recent advances in HSCT, Hematopoietic stem cell transplantation in Thalassemia. We are proud to have partners like PHO chapter of IAP and IAP Delhi, and eminent faculty like Dr. Naman Chandi, Dr. VP Chaudhary, Dr. Dinesh Bhurani, Dr. Sunil Bhat, Dr. Lalit Mehndiratta, and Dr. Manish Gupta. After deliberations by Dr. Bhurani and Dr. Naman Chandi, we have panel discussion and question answer from the participants, which will be moderated by Dr. VP Chaudhary. I'll request the participants to write their questions in QA so that we can read it and Dr. Chaudhary can answer it. Since topics are very interesting, and we have very eminent speakers in the field who have depth knowledge, I would not like to encroach upon your precious time, and let me introduce our chairpersons, Dr. Sunil Bhat. He is director and head pediatric hematology, oncology, and blood and bone marrow transplantation at Narayana Health Network Hospitals. He is honorary secretary, pediatric hematology and oncology chapter IAP. His awards are leading healthcare professional of the year 2018, besides other many publications and awards. Welcome, Dr. Sunil Bhat. Dr. Lalit Mehndiratta. He is a consultant pediatrician and neurologist, President IAP Delhi 2021. He is instructor IAP ALS program and author of Approaching Teens. Welcome, Dr. Lalit Mehndiratta.
Thank you.
Over to Dr. Sunil Bhat and Dr. Mehndiratta.
Good afternoon, everyone, and thank you, Dr. Arora, for and the National Thalassemia Welfare Society for having us all today, and thank you for the partnership with the PHO chapter as well as with the IAP Delhi. So, as you rightly mentioned, I think we have got the best in the field, and we have got the best, speakers, the best faculty who can deliberate on these two very important and very common topics, which we encounter in our day-to-day, hematology practice. So, it's a pleasure to introduce my friend, my colleague, Dr. Dinesh Bhurani, who doesn't really need introduction to this audience. Dr. Bhurani is Director of Hematology and Oncology and Bone Marrow Transplantation at the prestigious Rajiv Gandhi Cancer Institute. He has got enormous experience in bone marrow transplant and also other hematological conditions, both malignant and non-malignant, and is one of the first, DM hematology trainees from India, and has trained at the prestigious CMC Vellore many years ago. A lot of credit to him, a lot of publications and work he has done. So none better than him we can have to speak on immune thrombocytopenia and just what's the current management and diagnostic strategies. And there's a lot of things which have changed in immune thrombocytopenia recently. I think he'll be deliberating with us in the next few minutes on the ITP management guidelines. So over to you, Dr. Dinesh, for your talk. Thank you very much.
Good afternoon. Dr. Arora, my slides are there.
Yes,
Can they upload the slides? Okay.
Just a minute.
Yeah, sure. Dr. Maman is my teacher, so speaking in front of him makes a little nervous. But I'll try my level best to get it. We're going to talk about the ITP. Next slide, please.
Dr. Arora, this meeting is being recorded. Sign is coming up on the slides. Is that true for everybody or only for me?
It's recording.
But that is coming right on the middle of the screen. Is that happening to you?
No, it's on top only.
Okay, fine.
These are from this Novartis. Next slide, please. The next. So now go back the front slide. So that's it. Next slide. Can I ask for next slide, please? Yeah. So someone who wants to read about ITP, there are two publications. Can we go back to the Now, one more slide back. No, back. One more back. Yes, stay there.
There is center coming. Meeting is being recorded. Can this be removed, Dr. Arora? No, what
Okay,
is-
just a minute. शिवांगी, hello, Mr. Shivang.
Yes, sir. Yes, sir.
वो बीच में लिखा आ रहा है कि मीटिंग इज बीइंग रिकॉर्डेड, सेंटर में कहीं लिखा है.
Sir, it's showing on the left side of the screen, sir, on the left.
No, on R it is showing right in the center. Big
Sir,
one.
To me, it is on the left top, on the top only.
For on my screen, right in the center.
So I think you have to change view options at your end.
This one.
At our computer, it is on the top only.
sir, now it's okay, sir.
Yeah, now it is okay.
One slide forward. One slide forward. Someone is
Yes,
who is
yes.
holding one slide
Amar-
more forward.
Next.
Stay. Can we go one slide back?
Back.
Okay. What I'm trying to say, there's a lot of new guidelines have been published in the last 2 years. So there's a lot of modifications in the recommendations have come recently in 2019. One is from American Society of Hematology. These are the guidelines which were there in 2011, reviewed in 2019, and there are international consensus documents. So these two things are good to read it if we want to go into the depth of ITP. Next slide, please. Broadly, we divide it as a primary ITP and secondary. Secondary, we have some cause for this immune-mediated thrombocytopenia, and there are various causes for this. Roughly around 80% of the people have a primary ITP. We don't know the cause. Next slide, please. And then it is divided. It is acute, chronic, and persistent. Bleeding manifestation is very important, whether it is a wet purpura or is a dry purpura, or whether the patient is asymptomatic. The ITP one name is there, but the meaning or emergency depends on what kind of presentation is there. Definitely the mucosal, the wet purpura needs a treatment. We may not have to treat it. The asymptomatic or the dry purpura is not necessarily that every person needs to be treated. Next slide, please. These are the consensus document recommendations for the diagnosis. The diagnosis of ITP is principally on the exclusion of the other causes of isolated thrombocytopenia. So we need, it's not we have any definitive diagnosis, we need to exclude the other causes. That we do it by the complete history. So the history is important, physical examination is important, CBC is important, and expert analysis of peripheral blood film is important. So peripheral smear seen by an expert is very important because we need to exclude the other causes of isolated thrombocytopenia. Next slide, please. If like our region, especially in adult, if we think of H. pylori, we need to do appropriate test. Viral markers needs to be done. So hepatitis B, HIV, and Hep C should be done. If it's a pediatric case, good to do a quantitative immunoglobulin levels. Bone marrow examination is not routinely recommended, is recommended in the patients who are not responding to the initial treatment options, where you are planning for a splenectomy, or if you're finding any other abnormality, any slightest abnormality on the blood counts or morphology. Not doing a bone marrow, you need to have expert analysis on the peripheral blood. So if you are very comfortable, you know your bone marrow is absolutely normal, no steroids have been given in the past, then you can exclude the bone marrow biopsy. It's quite commonly we do it in the pediatric. Adult, usually we do it in our practice. I would like to have a lower this thing to do the bone marrow. So wherever there is a suspicion, and preferably in adult side, we would like to get the bone marrow done rather than directly going for the treatment, especially if you are planning for steroids. Next slide, please. Next slide, please. These are the recommendations given in the consensus guidelines, the basic evaluation in all patients. Go back. Who is controlling the slides? Yeah, stay there. Then there are some tests to be done in the certain patients and some are unproven or uncertain benefits. So there are a lot of tests written, but the someone which are basic things are to be done in everyone. There will be some differences in the opinion who should go for the bone marrow test. Next slide, please. What are the treatment goals? The important is the treatment goals should be clear in our mind. The treatment goal, the newly diagnosed and chronic phase, the goals will be different. The aim of the treatment is to prevent severe. The treatment should maintain a targeted platelet count of 20 to 30,000 for symptomatic patient, because the risk of major bleeding. Why do we need to treat this platelet count? Because the risk of bleeding, the major bleeding, increases exponentially above the below this. But in the symptomatic patient, treatment should be with the minimal toxicity. The treatment should not give a excessive toxicity, and the treatment should optimize the health related quality of life. The treatment itself should not affect your quality of life. Next slide, please. These are the two guidelines. There are slight variations. So below 30,000 who are asymptomatic have a minor cutaneous bleeding for the ASH. In the international consensus is more than 20,000. You don't have to treat in the absence of bleeding. So the treatment is not for the 1 lakh, treatment is not for the 70,000, treatment is for the 20 to 30,000, unless there is some other reason for the treatment. Next slide, please. What the treatment is, so the consensus is prednisolone. Usually is 1 milligram per kg if you are starting with the prednisolone. If it's a dexamethasone, in adult side is 40 milligram per day for 4 days. Pediatric, I'll come to this. It has to be given for few weeks, and so 2 weeks on the 1 milligram, maximum for 3 weeks, and should stop in the less than 6 weeks. So our maximum is 8 weeks. So if you take both the guidelines, there is a early taper rather than the later. So the continuing the steroid for prolonged, which is a routine practice we see in the society, which needs to be discouraged. What is important difference from the previous guideline? There is a clear emphasis minimizing the exposure to the steroids. And if there is no response to the initial dose within 2 weeks, the prednisolone should be tapered rapidly over a 1 week and stopped. So minimizing the exposure to the steroid, I think that's the important message from the recent guidelines. Next slide, please. This is where we have evidence. So initial treatment, steroid, IVIG, and NTD. There can be any type of steroid. So if you're using a dexamethasone, there is a different dose, probably high dose dexamethasone or prednisolone. Majority of the patient, if there is no emergency, preferably the prednisolone. The high dose should not be recommended in every patient to avoid a toxicity. But if there is an emergency, the high doses are recommended. The subsequent treatment, the robust evidence is for TPOs like altramopag, romiplastin. The new drug is fostamatinib and rituximab. There is no role of. There are many trials which show improved outcome with the TPOs and rituximab upfront along with the steroid, but that has not changed the practice. So these are not the standard this thing for and if surgical, there is evidence for splenectomy, but the recent guidelines defer the splenectomy for at least 12 months. We have many drugs which have shown efficacy, so not necessarily everyone should be on TPOs or rituximab. If the patient is not sick, the azathioprine, dinazole, dapsone, mycophenolate, some of the drugs which work in the patient's work. So we have enough evidence though it's not robust. We don't have the clinical trials with the comparative trials, but there is some evidence for these drugs too. Next slide, please. For the initial treatment, this is from IC. So the which I had summarized earlier is a prednisolone 1 milligram for 2 weeks, maximum for 3 weeks. And if you are using a dexamethasone, is 40 milligram. This is for the adults. Maximum duration is 6 weeks. If you're going for the longer, should not allow more than 8 weeks. And if there is no response to the initial dose of within 2 weeks, taper rapidly in 1 week and stop. Longer courses of steroids should be avoided unless you are on the lower dose. If you are on the 5 to 10 milligram, and if you think the patient is steroid dependent on the lower dose, then can be continued for longer. We should try to taper it earliest possible to keep the minimum acceptable platelet count. Next slide, please. IVIG is a role of IVIG. So if there is the severe bleeding, IVIG along with the steroid should be given. Someone is worried about the low platelet count, can afford IVIG, should be given IVIG. We should understand even NTD can be used. They have a temporary effect. Most of the people will have a lower dose, the counts will drop as soon as the IVIG effects goes. So they usually have a sustained, and it will have a prompt response, but it is a transient response in the majority of the patients. The TPORAs and the rituximab are not considered for the initial therapies. Next slide, please. Now we move to the treatment over the 3 to 12 months. Someone who has a severe bleeding, we throw everything in the front, depending on the severity, including some people may require a platelet transfusion also. If there's no severe bleeding, the majority of the people do not require a platelet transfusion. Once you come to this 3 to persistent disease, the primary treatment options are rituximab and TPO-RA. The splenectomy is usually discouraged up to the 12 months. Here you have to measure what is the patient's preference. If the patient don't mind to be on the longer treatment, the TPO-RAs, because they have a persistent higher responses. If the patient doesn't want to have a longer treatment, want to avoid a long-term medication, the rituximab is one of the drug of choice. Next slide, please. This is the similar thing for the 3 to 12 months. If we are going more than 12 months, there are 3 drugs: rituximab, splenectomy, TPO-RAs. These are drugs which have the evidence and are recommended by the guideline. But as I said, there are less robust evidence. Drugs are also there. Definitely, we should try some of these drugs, which may work into during the 3 months to 12 months, like cyclosporin, the dinazole, azathioprine, and dapsone. So we have a lot of experience with these drugs, which works in a few of the patients. Maybe around 20% of the patients, they do work. Then depending on the patient's what is a preference, whether we should be on the long-term TPO-RAs, whether we should go for the splenectomy, whether we should go for the rituximab. The TPO-RAs and the rituximab have a preference unless we have failed them over the splenectomy. Unless we have failed these, if we have failed these, then we should consider for the splenectomy. Next slide, please. These are the patient values and preference. So if you are worried about the low platelet count, whether you are accepting the low platelet count, the tolerance for the mild bleeding, what is the activity level, and someone wants to avoid a surgery, someone wants to avoid a corticosteroid, someone wants to avoid a long-term therapy. So these are the various preferences. In a 3 months to long-term treatment, probably we should take inputs from the patient, and that assessment should have a more preference against the physician's preference. Next slide, please. So there is some consensus. The medical therapy is preferred over a surgical therapy in the initial 12 months. First, more than 3 months, the medical therapies, the TPO therapy, RAs takes a preference over the others, unless someone wants to have a short-term therapy. We don't have to wait for 12 months for these 2 medical therapies. We should minimize or eliminate the use of corticosteroids during the initial therapy or a rescue therapy. There is no role of a long-term corticosteroids unless a very small doses. The older therapies have a role. reassess the diagnosis at each time point. Are you treating the same disease? Reassess the indication for the treatment, whether the patient needs a treatment. You may not need a treatment at each decision time point. And then definitely we should take preference of the patient into the consideration. Next slide, please. These are the various TPO-RAs which are being approved. There is a robust data with these agents. Next slide, please. This is a comparison between splenectomy, rituximab, and TPO-RAs. The first 1 month, the responses probably are similar, but the splenectomy is not preferred in the first 1 month. Durable responses, the TPO-RAs and splenectomy are roughly similar. The rituximab has a lesser durable responses. Remissions, they are higher with the splenectomy. You need to continue the TPO-RAs to have a continuous responses. You cannot stop them. There is a very few people TPO-RAs you can taken off. Rituximab, the remission is only 20% or 23%. Bleeding rates are almost similar in all these groups. Thrombosis is similar in all these 3 groups. Infections are higher with the splenectomy, and the surgical complications are definitely with the splenectomy. So this is a nutshell between these 3 options into the chronic treatment. Next slide, please. And these are the additional considerations. So there's a higher cost with the TPO-RAs. Rituximab can have a lower response rate, and some immunosuppression can be there, and splenectomy is irreversible, and you have a lifelong risk of some infections and thrombosis. Next slide, please. Next. This is with the Ultramopag. So these are in the clinical trials, which has definitely compared with the placebo, showed a consistent results over the long term with the Ultramopag. Next slide, please. Next. This is a real life data, which is the long term overall response rate of around 90%. And if you continue, there is a complete response of around 50%. Next slide, please. Next. This is go back 1. So the OR is 87 and the CR is around 80%. So there's a long-term data with the Ultramopag. If you continue Ultramopag, you have a significant durable responses. Next slide, please. Next. The bleeding episode significantly come down with the Ultramopag. Next slide, please. This is a 59% reduction in the concomitant medications, and there is 18%. Only 18% of the patients require a rescue medication. So if you are using them, you have lesser chances of requiring additional therapy with the Ultramopag. Next slide, please. And the fatigue, we didn't realize just a bleeding. Previously, we didn't realize the fatigue can be an important aspect of having during the ITP in the low platelet count, which had been recent in the recent decade. We have recognized this is important thing with not only the bleeding, the fatigue and the quality of life will be significantly affected. And if you increase the platelet count by the treatment, there is a significant response on the other parameters. Next slide, please. We need to realize there is an approximate time to respond to the second line treatment. So these are the various times. So we need to wait. If you're using a cyclosporin, if you're using azathioprine, if you're using a dinazole, you need to give a longer time for the drugs to work. It's not that you start the next day, 2 weeks and 3 weeks, you think that drug is not working. So we need to realize that if you're using a second line therapies, we need to give a time. TPOs have an earlier response than the other therapies. Next slide, please.
And Dr. Bhurani, if you could wind up.
Yeah, so that's what this is. I'll go to the keep going. Go to the summary slide. What I'm trying to say, this is a comparison between the earlier diagnosis, earlier treatment, and the subsequent treatment. With this, I'll stop it. Thank you.
Thank you very much, Dr. Bhurani. I'm sure it's so difficult to cover this in 20 minutes. Such a huge topic, and you have done. In fact, you have covered a lot of the ground in 20 minutes. We request you to stay put because I'm sure there will be a lot of questions on immune thrombocytopenia, and we'll take them in the panel discussion. So thank you very much for your time.
Thank you.
Now we move on to the next topic, and it's immense pride and pleasure for me to introduce Dr. Maman Chendi sir. In fact, sir is Padam Shri, Dr. Maman Chendi now, and if I'm permitted, the father of hematology and more importantly bone marrow transplantation in India. I think most of us who are in this field have directly or indirectly been trained and mentored by sir over the last many years, and there is no parallel example of the dedication and sincerity and mentoring so many of us in this country. So over to you, sir. I think there will be no one better than you to be talking on this topic. What's the recent advance in transplant? I know, again, it's very short time to be talking on this vast topic in 20 minutes, but I'm pretty sure that you will give us the main messages during your talk. So over to you, sir.
Thank you, Sunil, for your very kind words. And I'm happy to, over the next 20 minutes, try and give you a quick overview of the thalassemia transplantation. Just get my slides organized. Can you see my slides?
Yes, sir. Yes.
Yes. So thank you very much, Dr. Arora and Dr. Chaudhary, for having invited me, and thank you, Sunil, for your kind words. The first issue is choosing between transfusion, chelation, and transplant. I have a child with thalassemia. Do I go for transplant, or do I just continue transfusion chelation? Transfusion chelation, good quality of life, no complication, is possible with this approach. It's easier because of oral chelation. There is no effect on fertility if iron levels are properly controlled. There's no immediate mortality, and we hope that gene therapy will come. BMT has an immediate risk of mortality. There is a risk of relapse. Graft versus host disease can be a problem, and there can be effect on fertility. However, long-term transfusion-free, good quality life is possible with a transplant. For non-transfusion dependent thalassemia, if your HP is sitting around 6-7 grams, I actually prefer to go for a transplant, because if there is a donor, because by the time you're 40, you're badly osteoporotic, your quality of life is not good. So for a non-transfusion dependent, say an E beta thalassemia, who is running with a hemoglobin of 5 to 6 grams, I think transplant is certainly an alternative. This is a father's cry. Please, any information regarding a donor for my child. Through his 5 years now, he's crying so much. He doesn't want to go to hospital. He says I'm telling him a lie. When he goes to the temple, all he prays is that he never has to go to hospital. We can't control his sadness. So most parents are desperate to have a transplant when they have a child with thalassemia. Now we all know the Lucarelli classification, where if your liver is more than 3 centimeters, there is fibrosis, and you have not been properly chelated, then you are class 3, and your risk of a poor outcome with transplant is higher than if you're class 1 with no risk factors, and class 2 is intermediate. This is a paper published by Vikram Matthews with a new scoring system for class 3 thalassemia. And the difference, if you're low risk, that means you're less than 7 years and your spleen size is less than 5, your liver size is less than 5 centimeters, then you are low risk class 3. Your high risk class 3 if your liver is more than 5 centimeters for more than 7 years. And this difference between the low and high risk class 3 is very nicely seen in these survival curves from Dr. We all know that the outcome of a transplant depends on how well the child has been looked after before transplant. And in terms of being looked after well, has he been the hemoglobin constantly around 9? Are we using filters? was chelation started? What is the mean ferritin level? How regular are you with chelation? Has iron affected end organs like liver, heart, and endocrine organs? Have you had a hepatitis C, B infection? If all of these are not there, if looked after well, then you have a very good chance of having a good outcome with transplant, as shown in this slide from Pesaro, where if you're class 1, you have an event-free survival of 93%, class 2, 85%, and class 3, a little bit lower at 40 to 60%. This is Angaluki's slide showing that long-term, 20 years later, 70% of patients were transfusion-free, good quality life after an allogeneic transplant. Now, we used to use busulfan and cyclophosphamide plus minus ATG as standard conditioning. Today, for class 3, nobody will use that type of conditioning. Our conditioning today is with triazepa, fludarabine, and triosulfan. It's less toxic. There's a low incidence of VOD, slight increase in cost, but now with the drugs being made in India, it's not a big deal. And this is the difference in patients who were treated with the triosulfan TT regime as compared to Bucy. And you can see that the difference in long-term survival is really significant. Paper from Vikram from Velo. Now, what are the complications of transplantation and thalassemia? Infection during transplant is important, but today we seldom lose a child from infection in transplant. But post-transplant, we need to prevent coccal sepsis for 1 year, and we do that with penicillin. We need to prevent PCP with Septran, and post-transplant, child must be treated promptly if he develops a fever. There's nothing sadder than to lose a patient after transplant from a pneumococcal sepsis, which could easily have been treated quickly and well. Post-transplantation with immunization is important. And you start at 1 year and you give all of the vaccine. Now with Hexavac, life is much simpler. At 2 years, you can give a live viral vaccine. The MMR is given 2 years. That is B varicella or option. Now, rejection can occur in the immediate transplant phase, in which case you are likely to lose your patient. It can be late. Very few of our rejections are late. And when that happens, the hemoglobin starts dropping and the chimerism begins to come down. And this is how we monitor chimerism with a gene scan. And you can see that in the first, if that is the patient, that is the donor, you can see that post-transplant, we are not seeing any patient band, suggesting that it's a complete chimera. Regimen-related complications are mainly veno-occlusive disease or sinusoidal obstruction syndrome, hemorrhagic cystitis, pulmonary fibrosis, cardiomyopathy, and these can have late effects. After switching to thiotip or triosulfan, hardly see bad VOD that I used to see when we were transplanting with the older regime with busulfan cyclophosphamide. You must take care of iron levels. There's no point in transplanting and at 40 ending up with hepatocellular carcinoma. Start chelation at 6 months post-transplant. Never use desferal post-transplant because of the risk of mucormycosis. Now, the black fungus is what everybody is talking about. It's not really black. Blackness is only because tissues necrose when you get mucor infection. Fungus actually doesn't have any color, right? So try and bring the ferritin down to 1000 nanograms. After you've reached that level, then remove 8 ml per kg of blood every month till the ferritin comes down to normal, and normal is 150 nanograms to 300 nanograms. Getting the iron level down critical after a transplant and will improve quality of life. Take care of liver disease. If he was hepatitis C positive, today we have a good armamentarium of drugs to take care of hepatitis C. Graft versus host related, you have to look after. Fortunately, kids don't get the chronic graft. If there were endocrine problems at the time of transplant, then you must tackle these post-transplant. What about fertility after a transplant? These are some publications which suggest that if you transplanted early, before 10 years, you're likely to retain gonadal function. So therefore, if your transplant patient is 4 years old, chances are that he's going to have normal gonadal function. If he's 15, 20 at the time of transplant, you are not going to be so lucky. Pre-transplant counseling of parents regarding gonadal function and fertility is essential. When you run into trouble in a transplant, it's hard to face the parents if you have not properly counseled them about the risks and benefits of the transplanted by us. It's normal now. This is the second transplant done in Vellore many years ago. Now 23, he is 13 years post-transplant. He's a computer engineer working in Dubai. That's him with his father. And you can see that his height has caught up despite being transplanted at a late age. This kid is now in Canada, enjoying a normal life post-transplant. You look at him, he's perfect, like any normal kid, right? Now, suppose you don't have a sibling donor, then what would you do? You can have a cord blood transplant. You can have a matched, unrelated donor transplant, or you can have a haplo transplant. And Sunil here knows more about haplo than I do, right? So this is data on a cord blood transplant and data from abroad. This is Kabara, it's an old paper, but it suggests that cord blood can be as good. And you can see here that it's 5-year, 86% disease-free survival. No rejection, no problem. That is not the case in India. And this is data from abroad. This is data from China. And you can see again, the results are fantastic. But in our own country, if you look at the problem of rejection after cord blood transplant, significant. I don't have my own data because I don't do cord blood transplants, but Revati tells me that she's not enthusiastic about cord blood transplant for thalassemia. And this is data from Revati in Chennai. And you can see that the time that she shared this data with me, that with a matched family donor, long-term survival 88%, sibling cord and bone marrow match. So she combines the bone marrow with the cord. The results are good. Unrelated cord, it's only 60%. 10 by 10 matched unrelated donor, 100%. But you can see that 9 by 10 matched unrelated donor, 22%. And this is similar from data which Vikram has. Today, with the registries worldwide, there are millions of donors available. And the Dr. registry now has about 500,000 donors. There's a pretty good chance of finding a donor. But now in the COVID times, it's a bit tough to get a donor to come and donate. And sadly, about 25% matching donors refuse to donate when they're actually called upon to donate. And this is the cost from the different registries. It costs about 8 lakhs to get a matched unrelated donor with artery. And as I said, 9 by 10 is a no-no. Similar experience from Vellore. I'm not so, I'm sure that Raul would be able to say 10 by 10 full match, no problem. We're enthusiastic about doing those transplants. This is data from Vellore.
Dinesh Bhurani,
10 by 10 full mortality, alive 11 out of 15 transplants. Whereas 9 by 10, you can see that 7 out of 8 patients have not survived the transplant after a 9 by 10. Now, this is haplo transplant. This is personal communication from Dharma, but I'm sure that Sunil can tell us more about it. I myself have not started doing, but after talking with Revati, I feel that we should offer a haploidentical transplant to patients who are keen and who understand all the issues involved. This is TMC Kolkata. We have a beautiful hospital, that's children's ward. This is our transplant unit. Rooms are great, a lot of glass, you can look outside. It's a nursing station. We have very good cryopreservation laboratory. And in COVID times now, we are cryopreserving the marrow, the peripheral blood, so that we don't have trouble. And this is our team taken some time ago. Nurses are the backbone of our transplant program. We've done 23 transplants in 22 patients, no mortality, rejection 3, all are alive, median follow-up 22 months. It's an old slide. I'd like to acknowledge the transplant team in TMC Kolkata, my colleagues in Arora, all the people who brought thalassemia transplant to India with results that are comparable to the best anywhere in the world. Thank you very much.
Thank you very much, sir. I think it was, as usual, very simple, lucid, and very easy to understand. I think you have made it so simple in last 20 minutes to cover such a huge topic, and you showed us the history of transplants, mainly the thalassemia transplants in India, and also what's the data overseas. I'm pretty sure there'll be many more questions, sir, so we'll take them during the next session, which my co-chair, Dr. Lalit, is going to be introducing, and Dr. Chaudhary is going to be taking the panel discussion forward. Thank you very much for the opportunity.
Thank you, Dr. Sunil Bhat, and thank you, Dr. Meman and Dr. Dinesh. And I am really like to clap, Dr. Meman, the kind of job you are doing over the years, making the life of thalassemia free from any kind of complications. You know, it's a wonderful job. It's a new life. And Dr. Dinesh, a nice session on ITP. And for the panel discussion, we'll proceed for the questions. And for that, we have an esteemed guest with us, Dr. VP Chaudhary. I welcome him. He is a well-known hematologist of India. He's senior consultant presently at Fortis Escort Hospital, Faridabad, and of course, Batra Hospital Medical Research Center in Delhi. And he's been professor. We have read so many books written by him as a student, professor and head of hematology in AIIMS New Delhi, formerly. And he's the also expert member of National Policy on Thalassemia, Ministry of Health. He's the advisory and editor in the book of Advances in Hematology, and he's blessed with the award of Dr. Lifetime Achievement Award. So I welcome Dr. Chaudhary, one of the panelists. And second, I would like to welcome Dr. Ajay Gupta. He's the IIP East Delhi President and Central IIP Executive of IIP India from North Zone. He is the consultant at East Delhi Hospital and is having his own center, and is a well-known person and nice consultant, and he's the IIP Delhi. Welcome, Dr. Ajay. And I will give the session to Dr. Chaudhary to start the moderation of the session.
Just a minute, one please. I can see Dr. V.K. Khanna, Dr. V.K. Rugwani, Dr. Harish Pemde. I welcome you for joining the session. Over Dr. Chaudhary, please.
And Dr. Vinky also.
Yes, I told Dr. Vinky. Please.
Dr. Chaudhary, please unmute.
Sir, unmute kijiye. Sir, please unmute yourself. Dr. Chaudhary.
Can you hear me now?
Yes, sir. Yes, sir.
Dr. Meman Chandi, I'm very grateful to you for giving a very lucid talk. You have been a pioneer in the field of transplantation, and you were the first one to start at CMC Vellore and now continuing at Calcutta. Some of the questions which have come, and I'll start the ball rolling. You have transplanted hundreds of thalassemics. What has been the outcome of pregnancies in these boys and girls over Indian data, or even the, let us say, comparing with the other Western areas also? Dr. Meman, please.
Dr. Chaudhary, to tell you the truth, I do not myself have a patient who we have transplanted who has provided me any data of subsequently getting married and getting pregnant. I don't have that data, so I can't answer your question. Sunil, do you have any data?
So that's correct, sir. In our experience also, although I have been not there so long, so it's only a 10-year kind of this thing for me, but I haven't neither here or in Sydney come across a natural pregnancy after bone marrow transplant. But I think you showed a couple of case reports where there have been natural pregnancies after bone marrow transplant. So we will have to wait and see. With the triosulfan thiotepa conditioning, there is little promise of some children may have preservation of fertility, especially the children who are younger in age, and that data I think we still have to wait and watch. But till now, I think Dr. Rajiv Bansal has said that there is one patient who has got married and has natural pregnancy. So here we can there's an answer on the one of the panelists on the panel.
I know few of them have married, which were transplanted.
Marriage is, but not pregnant.
Marriage is okay.
I don't know the data, so I don't know.
Now, the question why I'm raising is many times when we go for the conference.
But Dr. Rajiv Bansal has at least one person who had a natural pregnancy.
Yeah.
Why I raised this question was when we go and talk with the various thalassemic societies and meetings, some parents are asking what will be the tomorrow's our children get married after BMT, whether they'll be able to have kids. I think since now there is a Indian bone marrow transplant registry and the CMC Vellore has been doing it. Maybe from their addresses, one can try to get the data, and that might be quite informative in this regard. The second will be, how was the Haplo, which is being, you think, are the result comparing with the sibling? Of course, the Haplo have poor. Will you recommend Haplo at the moment where in India, at least in this country, with the present facilities?
Dr. Chaudhary, I will just say that I myself was not enthusiastic, but I know that Sunil and Revati and people in the north from Jaipur have been doing Haplo with good results. So I would say the current international data suggests that haploidentical transplant for thalassemia is a feasible option with an acceptable morbidity and mortality. So if data from Vellore suggests that 85% was, when I was in Vellore, up to 300 transplants, our long-term survival for class 2 was 85%. So if there is a 15% problem with a matched sibling donor, I would anticipate that there can be a 20 to 25% problem with a haploidentical transplant.
Which means additional are only going up to 20%.
Total 20-25% chance of graft versus host disease, problems related to transplant morbidity, mortality. But I know that data from the Far East suggests that the results are no different from matched sibling donor. Sunil.
Sir, I agree. I think we have come a long way in haploidentical transplantation overall, but hemoglobinopathies in particular. And you're right, we have been doing it for the last almost 5.5, 6 years now. We presented our Haplo data in the ISBMT recently conducted, and we present our data for the depleted Haplo transplantations, and our experience is 89%. This is about 35 odd patients, 89 patients thalassemia-free survival. But I have to agree that we have not taken many class 3 patients. These are mostly class 1 and class 2 patients. There are two things. In fact, we compared our Haplo data with the MUD data, and MUD is 10 by 10. And we are, in our experience, the Haplos are doing better than MUDs. Lesser graft versus host disease because most of the patients have had depletions, and we have had lesser rejections because we do them pre-transplant immunosuppression. So I think there has been a learning curve over the period of time. And in fact, we now, in our experience, 10 by 10 MUDs and Haplos, we kind of, put them at par because the results in our center have been almost at par, and in fact, even better than 10 by 10 MUDs. Matched sibling donors, matched family donors, of course, they are the standard of care. They're better than any other type of donor. And that's one. The second is economics play a little role in haplo transplantation. They become more expensive because we end up doing pre-transplant immunosuppression, which takes a little time. Then if you're doing depletion, that also would be a little more cost added. And also the post-transplant care, which is a little more, I would say, intense as compared to a matched sibling donor for the few months post-transplantation. But yes, it's a clinical option, as you said, sir. If the family understands the pros and cons and the options available for them, I think this is one of the options which they can avail.
How much percentage overall is the cost difference?
So cost difference is almost, I would say 100% more, sir. If you get, if a center gives, for example, 100 rupees for, I'm just giving a relative number because the cost can vary from center to center, is 100 rupees for a match sibling donor, it will approximately 180 to 200 rupees for haploid transplant.
Okay, because of short of time, there are some questions from on the ITP. Dr. Dinesh, would you say when you really would ask for a bone marrow to diagnose, or where are the precise indication for bone marrow in ITP?
I'm sorry, because of the technical glitches, I had a few slides on the pediatric. They definitely differ from the adult side. There is a wakeful watch, and there is a spontaneous remission. So you need to have a higher threshold, at least for the starting steroids. So we missed it on the presentation. What do you say, bone marrow? How confident you are on your morphologist? So if you're very confident, there is no steroids have been used in the past, the peripheral blood is normal, at initial diagnosis, you don't need it. Adult side, we still practice to do it. But having a good morphologist is not an easy task. Getting the person who can give you the good quality peripheral smear is not easy. But the indications, so before splenectomy, someone had a multiple lines of therapy, and if there is any abnormalities on the peripheral blood, are the indications for the bone marrow transplant. The recommended indications.
How much, you are talking a lot of on thrombopoietin and with the from 3 to 12 months and beyond. How many percent of patients in India, these drugs are very expensive, are really able to afford, and you go straight after steroids to this group of drugs?
The other most effective therapy is splenectomy. So we should not be doing a splenectomy in the first 1 year. The problem with the rituximab is the long-term outcome is only 20%. So we are not, and the other drugs have a response in only 20%. So I agree, the majority we will be using the dapsone, dianazole, azathioprine, but now with the generic drugs, the cost is coming down. So we have a generic altromopag, we have a generic romiplastin. And more and more we are using TPORAs.
The another one, where you will label a patient to keep on getting attacks repeatedly. They recover altogether. There was earlier definition of recurrent or relapsing ITP. And now, and there are cases who get acute episode, recovered completely, 4 months, 6 months, or a year down, again they haven't. And you will see many patients who have 5, 6 attacks in their life. Where do you classify such patients?
Probably means some kind of either you call it them as a new, if there's a longer duration between, you can call it as a recurrence, but usually is a chronic ITP. Now, the majority will be
they have
qualifying for
recovered completely.
persistent.
I mean, their platelet count or 6 months remain above 150, So
Probably relapsed ITP. I mean, this doesn't come into the definition, but the
that is what I mean.
definitions
They don't go into
is by the duration. So if it is a prolonged duration, probably you can say the repeat, the relapse. But some of them may be chronic ones. Many times you don't check it in between. They may be chronic ones. According to the definitions, it will come into the chronic.
According to this, now with the current classification of ASH and other, it comes into chronic. Even if the patient has for 6 months or 2 years normal platelet count, and then gets another episode. Let us see the chat box. There are questions on the Rajiv Bansal stating that he has one post-transplant lady who had a natural pregnancy.
So there's one question from Dr. Rajiv Bansal. How is your experience with dapsone? Can one use dapsone in a female with ANA positive ITP?
Secondary ITPs, usually the dapsone doesn't work. In a primary ITP, there is a good data of the dapsone. We have used a lot in CMC Valor, and there was a reasonably good data. I think in secondary is difficult. You need a immunosuppression.
What was the data of dapsone in Vellore when you were there? You said
Dr. Maman can say more, but there's a publication by Dr. Sharad in dapsone's use. I think it's 20-30% of the people respond to dapsone. The long-term outcome is 20-30%, I think.
I have data where people have shown 40 to another one 55% with dapsone long-term recovery. Well, I mean,
probably 30%. Dr. Maman can tell us.
Dr. Maman,
you have to unmute yourself, sir.
I agree with Dinesh. The publication by Sharad Damodar looks at quite a large number, around 100 patients with treated with dapsone. I'm very enthusiastic about the drug. It's very, very inexpensive. Only problem is that 1 out of 1,000 patients can get a bad skin reaction in Stevens-Johnson syndrome. So the instructions you must give are two. One, get jaundice or you have a skin rash, immediately stop them. Many patients have mild hemolysis and it's worth checking the G6PD before you start them on dapsone. At children, I give 50 milligrams, adults I give 100 milligrams. And the trick with dapsone is not to stop it. Minimum duration should be 6 months. I have some patients with normal platelet counts with dapsone for the last 2-3 years. And I agree with you, there are patients who frequently relapse. And those are the ones who do well on dapsone. Keep them on dapsone for 2-3 years. Good quality life, no problem. In fact, they are loath to stop. They're reluctant to stop the dapsone. I think it's a very useful drug in our armamentarium. And the responses are about 60 to 70%, but the durable responses, as Dinesh says, are 30%.
I think more for an ITP, it has to be an individualized treatment for it, based upon the patient's symptoms, bleeding episodes, and then of course affordability and so on. One needs to keep in mind, and of course we have these thrombopoietins and which are very useful. Here's another question which comes. What is your experience with high dose prednisolone, 4 to 6 milligram per kg body weight?
If you see a pediatric guideline, there is a 4 milligram for a week. There is a short course with a higher dosage of prednisolone. I don't have a personal experience of higher doses. The only thing, the patient should not be infected. So if you're using a higher dose, the concern will be the infection. And we don't know whether this is better than the 1 milligram per kg. We have an experience with the dexamethasone high dose. It works faster, but it has not replaced the normal usual prednisolone. So asymptomatic patient, but the guidelines suggest the higher dose short courses are acceptable for the prednisolone. I don't have a personal experience.
You don't have.
So we have short of time. And we have to finish, please. Just one question, Dr. Alka Yadav. How to define and treat TPO refractory ITP?
How to define and I mean, I had to see the definition. So if there is any exact definition, but you have to give it for 3 weeks. And then if you give it, then you have to escalate to the higher dose and use it for another 2-3 weeks. And it's still that response is not there. Then it's then you call it as a refractory, but the exact definition I had to look at.
So if may comment, Dr. Bhurani, so
Yeah.
these are defined differently for the two TPO agonists which are being used. Eltrombopag is you give for 4 weeks. If you have no response after 4, you call them, they are not responsive to Eltrombopag.
No,
With
but
Romiplast, there is a dose escalation, as Dr. Bhurani was mentioning. Every week you do a dose escalation. And if there is no response after 6 weeks, in spite of the maximum dose, that will be refractory to Romiplast.
You can tell the pediatric dose also. Dr. Rajiv Bansal is asking the pediatric. Rajiv,
I will just like to have a few comments from our pediatrician also. This one thing, what is the age at which we should, when I diagnose a patient of beta thalassemia major, should prepare immediately after diagnosis? What age you recommend the bone transplantation is the best once the donor is available for autologous?
I personally prefer that the child is more than 2 years old. It's quite difficult to handle, even to measure blood pressure. that in a child who's less than 2 years old. And sometimes you get caught out with hypertensive encephalopathy because the BP wasn't checked properly. I think children should be between 2 to 4 years. I prefer 4 years actually, but 2 to 4 is a good age for us to handle. I know that centers have done transplants in babies who are 6 months old. My personal preference is 2 years.
Thank you.
One question, Dr. Khanna, please.
And one more thing, Doctor, before I call the expert, Dr. Dinesh, Eltromobag is being used in adult, you said in various slides. Yeah, what about the in pediatric age group? What are the results?
There are 2 trials which have been published with the pediatric age group also. So the Eltromobag has been recommended now in the pediatric age group too.
Dose is half, 25.
Yeah.
Thank you. But it is very expensive. It's very expensive. You know.
Its generics are available now.
Right. Thank you. And we can have comments from Dr. Harish Pemde and Dr. V.K. Khanna. Dr. Pemde sir and Dr. Khanna sir. Please unmute sir.
Thank you, Dr. Chandy, for a wonderful talk. I just wanted some clarification on haplo-identical bone marrow transplant, because till now we've been saying that it should be done by a very experienced person and should be considered as experimental. But I just heard, correct me if I'm not correct, that Dr. Sunil Bhat said that the results are better than mud of haplo-identical. Now, if it is so, then should we, if there is no HLA matched sibling, right from the beginning, should we prepare the patient and the parents for haplo-identical BMT? Dr. Bhat also?
So, sir, I think, I will try to answer this question before sir answers, because I think it was probably a little bit directed to me also. Basically, sir, transplant with thalassemia is always an option. If you lose a 2-year-old patient from a nice, resourceful family who could have managed the chelation and transfusion for the child probably very well, to a matched sibling transplant, it's a failure of the whole, process itself. So what I feel is that a transplant in thalassemia is not an emergency. It's not a only end of the road, like for example, we have leukemia, aplastic anemia, but it is an option which always the families have to take after understanding the pros and cons. So that is the first comment on the transplant itself in thalassemia. The second is then what, based on the donor, what would be the algorithm which we will follow. The algorithm which we follow is a first option would be a matched sibling, or followed by a matched family related donor, followed by a 10/10 mud, and their option of an haploid transplantation and a cord blood transplant. I meant cord blood, what I meant is on unrelated cord blood transplant. Unrelated cord blood transplants, the results have been extremely poor, both from our experience from India as well as abroad. And so that's kind of gone out of fashion because the rejection rates are quite high and immunoconstitution is very, very poor. Haplo transplant has come a long way in the last few years. And I think I did mention we have done around 300 odd haplos for children, not for thalassemia, but for various other indications and haplos, and hemoglobinopathies with sickle cell are about 50 odd patients. I had presented my data in 2017 ASH meeting, and recently we compiled it again for our ISBMT. And our results of haplo transplant in the range of 89% for thalassemia. But having said that, as I said, it's a learning curve and it's a little expensive exercise as compared to matched sibling donors. These patients take longer time. They need to be prepared for transplantation, what's called as pre-transplant immunosuppression, for almost a couple of months. They need to be chelated and transfused for many, many months before transplant if they're not in a good risk score. And of course, you need to have a high intense post-transplant surveillance on them and be able to follow them up very closely for a few months post-transplantation. So what I said was just my center's experience. So our haplo experience in covers mud is almost same, and in fact, I got a little better than muds because our GVHD rates with muds are a little higher, and that has kind of that kind of balances the outcomes. But if we overall look at it, it definitely is an option. For I don't still will call it experimental because the data is there now out from many groups, and I don't think it's an experimental therapy, but it's an option. And of course, as sir mentioned, the families who have to decide not for haplo, for any kind of transplant, whether it's a match sibling also. Sir, what to you? I think you can probably put it better than what I could do.
So I think I fully agree with you, but always there are these outliers. I saw one patient transplanted in another center in the north. It spent 1.5 crores.
Yeah.
The child came to my center severely infected and actually died at my center. He had had a haploidentical transplant. Now, I could say the same thing has happened to my patients who have had a full match sibling donor transplant. So, as you rightly said, every transplant carries a small risk, and the parents must fully understand that when they go in for transplant. With regard to haplo, I now agree with you for AML transplants in adults. I prefer to do a haplo rather than doing a mud transplant, even with a 10 by 10 donor. Our results with haplo and AML are better, they're easier to do, there's less GVHD. I don't have personal experience with haplo in children, but I agree with you that if that's what's happening in adults, then it should be similar for children. And therefore, if the parents understand the risk of any transplant, then I would say yes. And as I showed you, many patients are desperate to have a transplant. So if the only donor available is a sibling or a parent or a cousin who's half matched, go ahead with the haplo transplant if they understand the risks.
Thank you, Dr. Reddy and Dr. Bhat, for clarifying. Really, I had this doubt for a very long time in my mind, and thank you very much.
We are running short of time. And before closing, I have one question with both Dr. Bhurani or Dr. Mehma, that since COVID-19 is there, say COVID-19 vaccine can be given to ITP patients? If yes, to tell which platelet count, lowest platelet count.
Sir can answer it.
I would like to say that COVID-19 vaccination can produce thrombocytopenia. First patient was a doctor in the US who actually died of an intracranial bleed after COVID vaccination. But the risk is probably 1 in a million. One of my own classmates had a severe thrombocytopenia after COVID vaccination and required a lot of IVIGG, but finally now the platelet count is normal. So your question really is the other way around. If you do have ITP, can you have COVID vaccination? I would say yes. The risk of dying of COVID is greater than the risk of vaccination. And we know that even though COVID vaccination does not prevent, in our own hospital, 85% of our staff are vaccinated. We've had more than 100 vaccinated people getting COVID, but all mild disease, no admission, no problem. So I would say yes, you can have. If your platelet count is below 20,000, I would be a bit reluctant to give the COVID vaccination without first bringing up the platelet count. But I don't think there's data, and the American Society of Hematology suggests that patients with ITP should not be denied COVID vaccination.
Is it same with the hypersplenism seen in the thalassemia patients with the cytopenia?
Hypersplenism, even though the platelet count is low, they don't bleed. And therefore, I would say that the current NCCN guidelines for COVID vaccination in cancer patients is that even though their immune responses may be lower, it is better to immunize than not immunize.
Thank you, sir. We are running short of time. Thank you, Dr. Chaudhary. And I'm obliged to Dr. Mehmet Chandi, who pioneered BMT in thalassemia in India, and for sparing his valuable time to enlighten us on the current situation of HSCT in thalassemia. I'm thankful to my friend Dr. Bhurani for updating us on diagnosis and management of ITP. I think both have done a wonderful job by consulting with just 20 minutes knowledge in just 20 minutes to us. I'm grateful to my mentor, Dr. V.P. Chaudhary, for guiding me to organizing this webinar and eminently professionally moderating the panel discussion. My sincere appreciation to Dr. Sunil Bhat, Dr. Lalit Medaratta, for giving their consent to partner organizations which they represent to join with entrepreneurs in organizing this webinar and chairing the session. And my special thanks to participating doctors for sacrificing their afternoon nap to attend this webinar. Thank you very
sir.
much once again to everyone.
Thank you, Dr. Arora.
Thank you
sir.
very much.
Thank you,
Thank
Dr. Maman Chandi. Thanks, Dr. Bhurani.
Thank you.
Thanks,
you.
everyone. Thanks,
Okay,
Dr.
thank you, sir.
Thank you.
Thank you.